The global imagination has learned to see African hospitals through a narrow frame, dim corridors, aging equipment, urgency held together by improvisation, a place where help is always arriving from somewhere else. In this frame, expertise travels in. It comes with accents, credentials, and passports. It stands beside beds already occupied by people whose names are rarely remembered. Rwanda is often placed quietly inside that same picture, mentioned in summaries, grouped into regions, rarely paused on long enough to be understood on its own terms. What is usually missing from the story is not suffering, it is structure, routine, the slow discipline of people who work without expecting recognition. A provincial hospital does not announce itself. There are no press teams, no visiting delegations unless something has gone wrong. And when something does go wrong, the assumption is already in place that the solution must come from elsewhere. This assumption does not arrive loudly. It travels calmly, confidently. It sounds reasonable. It is rarely questioned. The world is accustomed to believing that when pressure rises, authority will reveal itself through titles, machines, and experience gathered far away. But there are moments when those assumptions are forced into a room with no space to perform. Moments where power does not introduce itself, it simply acts. This story begins just before one of those moments, before urgency compresses time, before hierarchy becomes irrelevant, before silence replaces instruction. It begins in a hospital that does not expect to be seen in a country often spoken about without being listened to. And it begins with a belief widely shared, rarely examined, that skill has a direction of travel. What follows does not argue with that belief. It does not confront it. It does not explain itself. It simply allows reality to proceed as it always does. The surgeon arrived in Rwanda carrying a reputation that had been carefully built over decades. His work was documented in journals. His hands had operated under lights that never flickered. Hospitals where he came from did not pause for uncertainty. In Europe, his days were measured by schedules that held. Power outages were a concept discussed in meetings, not an interruption felt mid-procedure. Machines responded when called upon. Support systems were assumed, not checked. When the invitation came, it was framed as assistance, a request for expertise, a chance to lend experience where it was needed most. He accepted without hesitation, not out of obligation but out of familiarity. This was a role he understood. Before departure, colleagues offered quiet encouragement. They spoke of difficulty in abstract terms, limited resources, challenging conditions, the kind of environment where experience mattered more than comfort. He listened, nodding. In his mind, the picture was already complete. A provincial hospital implied constraints. Young staff implied supervision. A visiting specialist implied leadership. None of these thoughts felt unkind. They felt practical, almost inevitable. He reviewed case notes during the flight. A possible cardiac surgery. Complications likely, equipment uncertain. He imagined what he would need to adjust, which protocols might not be followed precisely, where he might need to intervene. This was not arrogance, it was habit. Years of training had taught him that when stakes are high, decisions narrow toward those with the most experience. And experience, as he understood it, had geography. He did not expect resistance, he did not expect challenge. He expected gratitude expressed quietly and efficiency learned quickly. What he did not prepare for was silence of a different kind. Not the silence of disorder, but the silence of people who already know what they are doing. As the plane descended, Rwanda appeared calm from above, green, ordered, unhurried. It did not resemble the urgency he had imagined. He adjusted his watch to local time, unaware that time very soon would stop obeying anyone at all. The hospital did not announce itself with urgency. There were no raised voices when the surgeon arrived, no hurried explanations. It sat slightly removed from the main road, its walls warmed by years of sun and rain, its entrance shaded by a line of trees. Inside movement was steady, not fast, not slow. Nurses passed one another without words, exchanging small signals with their hands. Clipboards moved from one station to the next. Footsteps followed familiar paths. Nothing suggested chaos. The surgeon noticed this immediately. He had expected improvisation. What he saw was rhythm. The operating rooms were modest. Equipment showed signs of long use but not neglect. Every tool had its place. Every surface was clean. Introductions were brief, names exchanged without ceremony. No one paused to explain their credentials. The local cardiac team was younger than he anticipated. Most of them had trained in country. Some had spent short periods abroad, but they spoke of those years without emphasis. They asked him practical questions, not theoretical ones. What mattered was not what he knew, but what needed to be done. Schedules were posted on the wall, cases listed by time, not by importance. There was no rearranging to accommodate his presence. This unsettled him more than he expected. He watched as a nurse checked power backups with practiced attention. Another verified oxygen flow without being asked. No one waited for instruction. When he offered a suggestion about equipment setup, it was acknowledged politely, then absorbed into a process already in motion. He began to sense a quiet boundary. Not resistance, independence. Outside the operating wing, patients waited with families nearby. There was tension but not disorder. Names were called softly. People responded without protest. This was not a place performing under observation. It was a place functioning as it always did. The surgeon realized that his arrival had not altered the hospital's posture. No one stood taller, no one deferred. He was not unwelcome, but he was not central. And for the first time since accepting the invitation, he wondered whether his role here had been misunderstood, not by them, but by him. Preparation for the surgery began long before anyone spoke about urgency. The team moved with an ease that did not draw attention to itself. Instruments were checked and checked again. Sterile fields were laid out without conversation. Each person occupied a position that appeared chosen, not assigned. The surgeon watched closely, not critically, curiously. He noticed how responsibilities were distributed. No one hovered, no one rushed to prove usefulness. When a monitor hesitated, it was replaced without discussion. When a tray was missing an item, another appeared almost immediately, as if the absence had been anticipated. This was not improvisation, it was familiarity with limits. The local lead surgeon reviewed imaging, quietly tracing details with a finger rather than a pen. He did not announce conclusions. He simply nodded once and passed the file back. The visiting surgeon offered an alternative approach, something he had used often in better-equipped rooms. The suggestion was received with attention, not urgency. A brief pause followed, not to debate authority but to test practicality. The local surgeon responded with a short explanation, not defensive, not dismissive. The method would work, he said, if conditions held. Conditions here rarely held for long. They moved on. The visiting surgeon felt an unfamiliar sensation. His expertise was being filtered, not adopted. At one point, a nurse adjusted the lighting without asking. Another stepped in to assist, anticipating a need that had not yet been voiced. Hands moved with confidence, born from repetition, not from theory. The surgeon began to realize that much of what he had learned assumed abundance, redundancy, backup systems layered upon backup systems. Here redundancy existed in people, not machines. During a brief pause, he asked how often they performed procedures like this. The answer was calm. Often enough to know what mattered, often enough to know what could be sacrificed, often enough to know when to stop trying to control everything. As they prepared the patient, the rhythm held. No raised voices, no last-minute rearrangements. A nurse checked the generator status again. Her eyes lingered for half a second longer than before. No announcement followed. The visiting surgeon noticed this glance. It registered as a detail without explanation. In his own hospitals, a potential power issue would trigger protocol, alerts, escalation. Here it triggered readiness. He adjusted his gloves, aware that he had said very little in the past hour. No one had asked him to step back. No one had asked him to lead. His role had shifted without permission being requested or granted. He was still present, still respected, but the center of gravity had moved. When the patient was finally wheeled in, there was no dramatic pause. Only continuity. The surgeon felt something else than not doubt but recalibration. This place was not compensating for what it lacked. It was structured around it. And structure, he was beginning to understand, did not always wear the same uniform. The call came without warning. A collision on the highway, a bus and a truck, multiple injuries, arrival time uncertain. The hospital did not change its posture. It absorbed the information and continued moving. Patients began to arrive in waves rather than all at once, some walking, some carried, some silent in ways that demanded immediate attention. The surgeon felt the shift in the air before anyone said it aloud. Time began to compress. The generator was started as a precaution, not a response. Lights dimmed for a fraction of a second, then stabilized. No one reacted. Inside the operating room, preparation continued. Outside, triage unfolded with quiet precision. Beds were reassigned. Cases were reprioritized. No announcements were made over loudspeakers. The surgeon watched as the local team moved between spaces' hands, switching tasks without hesitation. There was no visible command center. Leadership was embedded in action. He asked whether the surgery should be delayed. The answer came quickly. No. Waiting would cost more than proceeding. The power flickered again, this time longer. Machines paused. Silence filled the room. The surgeon felt his body tense, his instincts reaching for systems that were no longer there. He looked toward the local lead surgeon, expecting instruction. None came. Instead, the team adjusted. Manual instruments were positioned. Position shifted slightly. Breathing slowed. The flicker passed. Power returned, imperfect but present. No discussion followed. Outside, the flow of patients continued. Inside the window for decision narrowed. The surgeon realized that the crisis was not arriving. It was already here, and it was not announcing itself. This was not the kind of pressure he was used to. There was no dramatic escalation, no raised voices. Only the steady understanding that whatever happened next would be handled by those already in motion. For the first time since entering the hospital, the surgeon understood that his usual advantages, authority, experience, expectation, had lost their shape. What remained was participation, and participation here required listening. The equipment failed without explanation. Not all of it, just enough. A monitor froze mid-reading. The backup hesitated longer than expected. Power held, but unevenly. In another setting, this would have stopped the procedure. Here, stopping was not an option. The local lead surgeon made the decision without announcing it. His hands moved first. The rest of the room followed. The visiting surgeon felt the moment stretch. He understood what was happening. He also understood that his usual response, calling for replacement systems, escalating to administration, meant nothing here. There was no one to call. The team shifted into a different rhythm. Manual checks replaced digital confirmation. Eyes replaced screens. No one asked the visiting surgeon for permission. No one waited for his approval. This was not defiance. It was continuity. He considered intervening. A suggestion formed, then dissolved. He realized that his hesitation was not about confidence. It was about relevance. The decision had already been made by people who would carry it through. As the procedure progressed, the surgeon saw something unfamiliar. Not improvisation, but prioritization stripped to its essentials. Steps he would normally insist upon were bypassed, not recklessly, deliberately. What mattered was not procedural purity, it was outcome. The room was silent except for breathing and movement. No one narrated their actions. In that silence, the visiting surgeon recognized the reversal. Everything that had brought him here, the reputation, the authority, the assumption of leadership, had become weight without leverage. His presence still mattered, but not in the way he had expected. He adjusted his position not to take control but to support. For the first time, he followed someone else's lead in a setting where his instincts screamed to command. The procedure stabilized. No celebration followed, no acknowledgement. The team continued working as if nothing extraordinary had occurred. The moral shift did not arrive with a speech, it arrived with effectiveness. Money could not restore the power. Experience could not override the decision already in motion. In that room, at that moment, authority belonged to those who knew the limits and worked within them. And the visiting surgeon understood that something fundamental had changed not in the room, but in himself. The surgery did not end with relief, it ended with continuation. The patient was transferred without ceremony. Post-operative routines resumed immediately. There was no pause to mark success. The visiting surgeon stepped aside, not instructed to, but aware that the work ahead no longer required him at the center. He observed from the periphery, a place he had rarely occupied. The local team spoke in short exchanges. Nothing was explained for his benefit. Nothing needed to be. He noticed how fatigue was managed. Shifts overlapped just enough. Hands were replaced before they trembled. There was no visible pride in having managed the crisis, no recounting of decisions made under pressure. This was simply how work was done. When the lead surgeon finally spoke to him, it was not to claim credit. It was to ask a practical question about follow-up care. The visiting surgeon answered carefully, aware now of his position. He offered insight where it fit. He held back where it did not. Later, in a quiet corridor, he realized the inversion had completed itself. He had arrived expecting to lend structure. He was leaving having learned it. The hierarchy he carried with him had dissolved without confrontation. No one had challenged his status. It had simply become unnecessary. The team returned to their routines. Patients continued to arrive. Power flickered once more and stabilized. Life inside the hospital did not reorganize around what had happened. It absorbed it and moved on. For the first time, the visiting surgeon felt the weight of what he had assumed and the lightness of releasing it. Respect here was not requested, it was demonstrated. And it did not require acknowledgement to remain intact. By morning, the hospital had returned to its usual rhythm. The corridors were busy again, charts moved from hand to hand. Names were called, softly answered without hesitation. There was no reference to the night before, no summary meeting, no narrative constructed around what had occurred. The visiting surgeon walked through the same entrance he had passed days earlier. Nothing about the building had changed. The walls bore the same marks. The equipment remained the same. Only his way of seeing it had shifted. Outside families waited as they always did, some anxious, some calm, all patient in a way that suggested familiarity rather than resignation. He paused before leaving, looking back once, not to mark a conclusion, but to register an absence. The absence of spectacle, the absence of explanation. What he had witnessed would not travel easily. It did not fit into presentations or reports. It could not be reduced to a lesson without losing its meaning. On the drive away, the landscape unfolded quietly. Green hills, roads in use, life continuing without reference to who had passed through. Rwanda did not ask to be reinterpreted. It did not ask for acknowledgement. The hospital would face another crisis soon enough. Another moment when assumptions would again meet limits. Whether anyone else would notice the reversal was uncertain. But the surgeon knew that something essential had been revealed, not declared, not defended. Simply practiced. and that knowledge would remain with him unannounced long after he returned to places where power rarely flickered and authority was rarely questioned. The story, like the hospital, did not end. It continued.